Welcome to Grand Rounds, July 2021. Today we have Dr. Brittany Hilderbrandt and Dr. Jessica Wagner talking to us about integrating balance and hearing loss. Dr. Hilderbrandt graduated with a Bachelor's of Science degree in biology from Bloomsburg University, and then earned her Doctor of Audiology also from Bloomsburg University. She offers experience in comprehensive audiometric testing for all ages, auditory brainstem response testing, balance testing, and hearing aid treatment options. Her philosophy is a clinical approach to hearing healthcare that is based on research and centers on assessing the individual needs of patients. In her spare time, she runs a local CrossFit gym with her husband and enjoys hiking with her 2 dogs. Dr. Wagner graduated with a Bachelor's of Science degree in communicative disorders and subsequently a Doctor of Audiology from Northern Illinois University. Before joining the audiology team at St. Luke's, she practiced at Penn State Hershey Medical Center. Dr. Wagner is passionate about providing excellent family-centered care to all patients. Her clinical interests include pediatrics, vestibular, and electrophysiology. In her spare time, Jessica enjoys running half marathons and snowboarding. So for those of you who are looking for continuing education credit, the registration for being in here is tied to your Teams login. So if you're calling in, please also make sure you go into Teams and log in. If you don't have the ability to do that, please email me just so that I know you are here. And then if you're watching the recorded version, please make sure you complete everything on My eLearning. For those of you who are live, you'll get a link for the My eLearning directly. So without further ado, I will turn this over to Dr. Hildebrand.
Hello, thank you for joining us today. So again, we're going to talk to you about audiology, the basic concept of audiology and what most people think of when they think of an audiologist, which is the comprehensive hearing test. And then later, we're going to talk to you more about the balance side of our profession. This is our designation statement, as well as our disclosure information, which we have nothing to disclose, and our learning objectives for today. So I want to jump into the scope of practice for an audiologist. So as it was mentioned, as an audiologist, we do get our doctorate degree. So I did 4 years of undergrad, as well as 4 years of graduate school. Audiologists can work in a number of settings, including a hospital setting to private practice, as well as educational audiology. So there's quite a few avenues that we have available to us. Part of our scope of practice includes quite a few things that people may not be aware of, so I want to review that. Again, the first thing that most people think of is the diagnostic comprehensive testing that we do perform on infants up to adults. We do provide rehabilitation and treatment of hearing aids for people with hearing loss, balance testing, which Jess will get into later, electrophysiology assessments, as well as facial nerve monitoring and intraoperative monitoring, which is actually done on brain surgeries and spinal surgeries. We provide all of these services here at St. Luke's, aside from the intraoperative monitoring and the facial nerve monitoring. So I want to jump into the science behind how we hear, just briefly. So again, our ears are what collect the sound, and then our brain is what processes it and understands it. So again, the sound is being collected, transmitted through the auditory pathway up to the auditory cortex, where there are several areas of the brain that are designed to detect and interpret speech and make it meaningful to us. So just a brief review of the anatomy of the ear. We do have 3 parts to the ear: our outer ear, which is the part that you can see on the head, our pinna, our ear canal, where you can get wax and where you shouldn't be putting Q-tips. At the very end of our ear canal, we have our eardrum, which starts our middle ear, which is a chamber. And in healthy individuals, this chamber is typically air-filled. In our middle ear is also our eustachian tube. So anytime you fly in a plane or drive up to the mountains and you feel that popping sensation, that is our eustachian tube opening and closing to regulate the pressure of our middle ear. We also have the 3 tiniest bones of the body in there that work as a lever system to continue the transmission of sound into our inner ear and our cochlea, which is our hearing organ. And it's this little snail shell shaped organ As well as right there, we have our vestibular system. So our vestibular system and our cochlea are actually housed in the same bone. They share the same fluids, which is actually why you see audiologists perform balance testing. Our vestibular system is made up of 3 semicircular canals, a saccule, and a utricle, and Jess will actually get into those in a little bit more detail later. So I do want to review with you again the most common thing that you think of when you think of an audiologist, which is a hearing test, where we ask you to raise your hand for those little beeps. So we're looking for a couple of things. First, we're looking for the degree of hearing loss. So, we're looking for normal for the most part, but there are deviations from normal, which can range anywhere from mild all the way to profound. We're then looking for configuration, so the shape of the hearing loss, which again can range depending on why the person has hearing loss, what it caused it, and everything. So again, that can range anywhere from normal sloping to profound. We can have any sort of configuration out there. The last thing that we're looking for is type. There are 3 types of hearing loss: sensory, neural, conductive, and mixed. We find these by comparing our air conduction thresholds, which is when we test the ear using all 3 parts, so the outer, middle, and inner ear. Then we compare those thresholds to our bone conduction thresholds, which is when we isolate the cochlea and test that on its own, which is removing the outer ear and the middle ear and avoiding any issues like impacted cerumen or middle ear disorders like an ear infection. So I do want to review the audiogram, and this is essentially what I review with my patients after I see them. So when we look at this graph over here, when we go across the top, left to right, we're looking at pitch. So if you think of a piano keyboard, over here on the left-hand side, we have our low, bassy pitches. And then on the right-hand side, we have our higher, squeakier pitches. Now, what that means for speech and language, in the lower pitches is where we find our vowels, which is what gives our voice its volume. And in the higher pitches is where we find our consonants, which is what gives us clarity and understanding. So there's always 2 parts to hearing. Did I hear it and did I understand it? And I'm going to come back to that. Top to bottom, we're looking at volume, 0 being very soft like a whisper, 120 being very loud like fireworks, and then 50 right here in the middle is normal conversational volume. So roughly the volume that friends, family, coworkers are speaking at. I tend to be a little bit louder than that, but typically speaking, that's how loud people will be talking. And again, this gray box, it's kind of hard to see, but anywhere 20 and above is considered normal hearing for adults. So I do want to plot a hearing loss. That's actually one of our patients we have. So again, we're plotting the softest sounds that you can consistently respond to. So when we look at this, as you can see, it ranges from start to finish. So I'm sure some of you have heard of percent of hearing loss. And as an audiologist, we really don't use percent of hearing loss. And as you can see, because the start of this hearing loss is very different than the end of this hearing loss. So more often you'll hear us say that this hearing loss is normal sloping to profound. And that's how we want to quantify and classify hearing loss. So for this patient, as you can see, they have normal hearing in these lower pitch sounds. And then we dip down very steeply to a profound hearing loss and even a no response in these very high pitches. So this patient, for the most part in everyday life, is not going to so much struggle hearing you, but they're going to struggle understanding exactly what you're saying. And I'm going to get into that in a little bit more detail in just a minute. So to further break down the audiogram, as I mentioned, across the top, we're looking at low pitch up to high pitch, and then volume soft to loud. Again, our hearing can range anywhere from normal all the way down to profound. Over here on the right-hand side, we have our speech banana, and this is actually a fun image that we use with our patients. It actually plots common sounds, the pitch that they're typically at, and the volume that they're typically at. So you can see here we have a low, bassy, loud dog bark, and then up here we have a very high-pitched, very soft bird chirping. As well as on this graph, we can see our speech sounds. So as I mentioned before, the lower pitches is where we find most of our vowels and meaning, and then our consonants, which gives us clarity and understanding. So if we plot that same hearing loss that we just saw, we can see that in the lower pitches above this blue line, which is normal conversational volume, this patient isn't going to struggle so much to hear some of these sounds without the use of a hearing aid. They're hearing this normally. But then all the way over here, we can see that this patient is not able to hear any of these sounds without the use of a hearing aid. So I always say that this is like talking to a patient and telling them that I have 20 hats, but they hear I have 20 cats. It's a very different thing to tell a patient. But again, that's where that hearing and understanding comes into play. So it's very important that we know the softest sounds, but it's almost just as important to make sure that that you can still understand the information once it gets through that pathway. So after we find, again, the softest sounds that you're able to hear, we also test speech. So again, that's that part, did you hear it and did you understand it? So again, it's very important that we know the softest sounds, but it's also extremely important that we make sure that the brain is still capable of understanding the information once it gets up there. So again, we do several testing for speech understanding and word recognition. Again, we want to make sure that that pathway and the areas of the brain are still strong and are able to understand speech again once it gets through that pathway. And just a side note here, and these images can kind of show you, in today's world with all of the masks, it's making it that much harder for patients to understand people, especially with hearing loss. The masks are not only distorting speech and making it harder for people to clearly understand, but a lot of patients who have hearing loss will instinctively start to lip read, and obviously with a mask on, they can't do that. So again, it is making it much harder for hearing impaired patients to understand people in their daily lives with the masks. So I want to just review a couple of hearing loss facts. Some of these were actually even surprising to me when I looked them up. The one that was most surprising is that hearing loss is the third most common chronic physical condition in the United States and is more prevalent than diabetes or cancer, which again was kind of shocking even for me to find out. I feel like hearing loss, unfortunately, sometimes has a stigma that it is only for adults. Mostly adults are suffering from this, and I can tell you that that is not the case. 2 to 3 children out of 1,000 that are born in the United States every year are born with hearing loss in 1 or 2 ears. 1 in 8 adults, or I'm sorry, 1 in 8 people, roughly 30 million people 12 and older, also have hearing loss. We do certainly see an increase as we get older. So again, 1 out of 3 individuals 65 and older have hearing loss. But again, it's something that affects everyone at all ages, different severities, and for different reasons. So really what I want to talk to you guys about today is the link between hearing loss and cognitive decline and dementia. Hearing loss is associated with other medical conditions such as kidney disease and heart disease, but today I really do want to focus on that cognitive decline and dementia. This is something that we deal with pretty frequently in the clinic as far as the long-term effects of untreated hearing loss. So as I mentioned, there is a link between hearing loss and dementia. A number of studies have been done over recently and have identified this link. Previously, there was a perception that hearing loss is relatively inconsequential part of aging, and recent studies have actually kind of changed that and found that hearing plays a much more important role in our overall brain health, and that's kind of what I want to get into. And again, as a side note, in our profession, we hear a lot from our patients that they have been previously told, you hear great for your age. And I always think of that as like if someone were to walk into a physical therapy office and they're 75 and limping and you say, well, you walk great for your age. It's not necessarily appropriate. You know, if there's any sort of deviation from normal, we certainly want to make sure that we're addressing it, making sure that the patient is aware of all the treatment options available to them so that they can lead their best, most successful lives. So again, as I mentioned, I want to kind of jump into the effects of long-term untreated hearing loss. So again, what if we do nothing after we find out we have hearing loss? Again, as I said before, we don't necessarily hear with our ears, we hear and understand with our brain. So we want to make sure the brain is staying nice and active. So there's a couple of theories out there as far as the link between cognitive decline and hearing loss, and I want to review those with you. The most common one, and actually one that I review with my patients pretty frequently, is the use it or lose it theory. So this theory is suggesting that cognitive impairment due to hearing loss is happening in one of two ways. The first way is stating that due to long-term auditory deprivation resulting from hearing loss, the areas of the brain, specifically the auditory cortex, are starting to lose functionality. So if we think of the brain as a muscle and we're not working it out and we're not using it over a long period of time, we start to see a decrease in functionality. So this is suggesting that there are changes occurring to the gray matter of the brain, causing a decrease in neural activity available to perform cognitive tasks. So this reallocation or lack of resources is affecting the brain's integrity and overall function, thusly affecting an individual's cognitive ability. And again, that's what this slide is depicting. So we have that degraded auditory deprivation. We're starting to see changes in the brain, which change the integrity, the brain volume, as well as our cognitive ability. The second way that this theory suggests is that when we have communication breakdown, we see a reduction in quality social interactions for patients, which can lead to social isolation or withdrawal from normal activities, which can then lead to depression, which has also been shown to additionally affect cognitive function. So research indicates that even a perceived social isolation is a risk factor for poor overall cognitive performance and faster cognitive decline. So these impairments that are related to hearing loss can cause a cascade directly or indirectly leading to cognitive impairment. So the other two hypotheses as well is the cognitive load, which is talking about effortful listening, and then neurodegeneration. So cognitive load is the cognitive effort or amount of information processing required by an individual to perform a task. So the basic idea is that if a task requires too much cognitive ability, the completion of that task will be hindered due to limited cognitive capacity. So when we're talking about a person with hearing loss, cognitive load comes into play with listening effort. Listening effort refers to the amount of concentration and attention required to understand speech. So when a person has hearing loss, auditory signals become degraded, which requires more cognitive resources simply to understand speech and understand it. So that's where that effortful listening comes in. So an individual with normal hearing has ease of listening, whereas an individual with hearing loss has to put forth a lot of extra effort and energy simply to listen and understand, which then causes a diversion of other cognitive tasks, resulting in cognitive depletion. So again, that's what this image is depicting. We have a normal hearing individual. We have our 6 cognitive resources. We require 3 for auditory processing, and then 3 can be devoted to other cognitive tasks. On the other side, we have a hearing impaired individual, the same 6 cognitive resources, but because this individual has degraded auditory input, they're requiring more cognitive resources to simply understand speech, which then we're seeing this diversion of cognitive resources that are available for other cognitive functions. So when this is happening and a patient is exerting extra cognitive load for auditory processing on a daily basis, we can see long-term structural changes of the brain, and neurodegeneration can start to occur, which can affect other cognitive processes. I knew it. So this is thus starting a cycle in which cognitive resources available to perform tasks are limited or reduced. So again, regards to a hearing impaired individual, resources being diverted to auditory processing are then being taken away from other cognitive resources. And with this continuing to happen long term, we can then see potentially further cognitive decline. The last one is the simplest theory out there, and this is the common cause. This assumes that there is an existence of a common factor that is responsible for age-related deterioration in cognitive and non-cognitive processes, and proposes that age-related declines are shared across multiple and seemingly incongruent functions. So again, this is just assuming that age-related loss and deterioration stemming from genetic factors, oxidative stress, or even circulatory insufficiency, we're seeing cognitive decline resulting in both pathways. All three of these theories have social isolation and depression associated with them, and that's the next thing that I want to discuss. So, social isolation, depression, and hearing loss. Studies have repeatedly shown that social isolation is arguably one of the biggest predictors of morbidity and mortality in older adults. Social isolation relates to poorer outcomes through several different pathways. The health and behavioral pathways can be affected by things such as adherence to medical treatments, such as hearing aids, as well as smoking, diet, and exercise. Psychological pathways are impacted by a person's self-esteem, self-efficacy, and sense of well-being. So when we're talking about a patient with hearing loss, back up, there we go. So when we're talking about a patient with hearing loss and we see verbal communication or lack of social interaction, individuals, for an individual with hearing loss, this can severely reduce an individual's social interaction. So reduced socialization is known to occur along with loneliness, apathy, and depression. Research has shown that even perceived social isolation is a risk factor for faster cognitive decline, poorer executive functioning, increased negativity, and overall poorer cognitive performance. So this is suggesting that social isolation and depression as a result of hearing loss may indirectly or directly cascade and lead to cognitive impairment. So what now? So we just discussed several ways that untreated hearing loss can affect individuals' cognitive function and overall health and well-being. So we certainly want to do something about that. And what we can do is fit these patients with hearing aids. So the answer is hearing aids. Hearing aids come in all shapes and sizes, colors, technology levels. Some of the cool new features of hearing aids is Bluetooth capability, as well as rechargeability, so no more batteries. But again, at the end of the day, the hearing aid is there to help you with your hearing. Hearing aids are not like glasses. They are not corrective. They are not giving you back normal hearing. It's in the name. They are going to aid you in those environments that you're struggling in. Some patients with hearing loss that are fit with hearing aids are still going to struggle in certain situations. And that's where we come in with appropriate expectations as well as counseling with our patients. On average, it takes people 7 years to do something about a hearing loss after they've been identified with a hearing loss. So again, we really want to start that conversation as soon as possible so that we can get this process started as quickly as we can. Again, we talked about those negative side effects of untreated hearing loss. In addition to hearing aids, there are other assistive listening devices. There are devices that connect and stream your TV directly to your hearing aids. It helps keep these patients connected to the things that they enjoy and love. There are other implantable devices, which really depend on the hearing loss and the type and severity of your hearing loss. We already talked about what happens if we do nothing, so we certainly want to avoid that the best we can. And then again, we're back to fitting hearing aids. So there's a lot of changes that are going on in our world with hearing aids as far as insurance and where patients are able to get them. At the end of the day, an audiologist is your best bet. This is what we do for a living. Again, we go to school for 8 years. We understand the theory and research behind hearing loss and what goes into it as far as managing expectations and making sure patients are appropriately fit and counseled. Patients come in all the time with mailers about mail order hearing aids. They can get them from Costco. I'm sure some of you have seen that, as well as over the counter from pharmacies. I tell most of my patients that, if you only want to pay $100 for a hearing aid, you're only going to get about $100 worth of benefit. I'm at work 5 days a week. I'm there to make any adjustments or changes and work with the patient so that, again, they're going to do their very best. So patient's best bet is to see an audiologist if they're concerned about their hearing. So some of the key takeaways from all of this, researchers have found that elderly adults with hearing loss who are treated with hearing aids had similar rates of cognitive decline compared to adults with normal hearing sensitivity, which is suggesting that hearing aids may attenuate cognitive decline that can be accelerated by hearing loss. It was also reported that hearing aid use is positively associated with episodic memory scores, or an improvement in episodic memory scores, and the decline is associated with was slower after the use of hearing aids. So again, this is driving home that point that we need to start the process as soon as possible with these patients. Again, on average, it takes patients 7 years to do anything about a hearing loss, and we certainly want to speed up that process the best we can. Hearing aid use has also been shown to boost self-efficacy, which can have a positive impact on performance on cognitive tasks. It can improve their feeling of self-worth, and then again, reduce social isolation and depression. It was also reported that maintaining strong social connections, one can prevent cognitive decline and prolong the onset of dementia. So again, in the hearing loss population, we're seeing people voluntarily isolate themselves due to their hearing loss and due to communication failure. So then can we not say that by wearing a hearing aid and being able to maintain strong social connections throughout life, that we could then reduce the risk of cognitive decline and dementia? So this is wrapping up is where we ask that the referral is made. Again, making that referral as soon as you notice any issues is certainly going to help the patient. Again, I mentioned it numerous times, 7 years for patients to do anything. We talked about the long-term effects of untreated hearing loss. So again, we want to avoid that the best that we can. And lastly, this was just something interesting that we found in some of our research that kind of has the flip side of it. So they asked, what if hearing aids are not necessarily causing better cognition, but rather already more cognitively abled people are more likely to seek a specialist, such as an audiologist, or seek hearing aid treatment more readily than less cognitively abled people from the start. So this then becomes the responsibility of other healthcare professionals to make the referral when patients are either complaining of hearing difficulties, or while you're in an appointment with them, they seem confused, they have to have you repeat yourself, they're answering inappropriately. You know, those are all signs that the patient is having some hearing difficulties and should be referred to an audiologist. So again, we can at least see what's going on and start that conversation as soon as possible to prevent any of those long-term effects that we just talked about. That's it for my portion. If there's any specific questions, we can answer that now. If not, Jess is going to talk to you about balance.
We good? Okay. All right. Hello, everyone. Welcome to spin class now. So we're going to show that bubble again. Just going to shift the change. So as Brittany discussed the cognitive decline and the dementia, I'm going to actually talk about where the risk of falls and just our balance in general comes into play. So first off, I just want to talk about some facts. So first off, there's 35% of adults aged 40 years or older in the United States have experienced some form of a vestibular dysfunction. 80% of people aged 65 years and older actually have experienced some form of dizziness. 50% of individuals complaining of dizziness actually have BPPV, which stands for benign proximal positional vertigo. This is actually the most common vestibular disorder. So I mentioned falls in that little bubble. So I do want to touch on some facts about falls. So 1 out of 5 falls actually causes a serious injury. So that being said, 800,000 patients a year are actually hospitalized because of a fall injury. Now, most of these injuries are resulted from the fall are head injuries and hip fractures. Falls affect 33% of individuals over the age of 65. It actually goes to 50% once they go over the age of 80. The death rates actually from falls have increased within the last decade, about 30% now. Falls are the leading cause of injury-related deaths among adults aged 65 and older. And falls are one of the main causes of traumatic brain injuries, or what we label as the TBIs. So on the TBI stance, I do want to touch on concussions, especially because we do have some physical therapists attending today. So according to the CDC, it estimates about 1.6 to 3.8 million sports and recreational related concussions occur each year in the United States. On average, 40 to 60% of patients experience some lack or loss of balance following a variety of head traumas. A concussion can actually affect and damage any of the system utilized to maintain our balance. Now, an athlete who sustains a concussion is actually 4 to 6 times more likely to sustain a second concussion. And actually, traumatic brain injuries occur every 15 seconds, which is kind of scary. And I think even the more scarier point is 5 out of 10 concussions actually go unreported or undetected, which being a former athlete myself, I can see how that is, because you don't want to sit, you want to play. So touching on concussions in sports, I did want to show a little bit of facts about pediatrics and their balance system. So 1 in 20, so about 3.3 million children between the ages 3 and 17 actually have dizziness or a balance problem. I'll get a little bit more into how that can break down, but good to know that girls and non-Hispanic white children actually have an increased prevalence of dizziness and balance problems. About 20 to 70% of children with sensory neural hearing loss, so something that Brittany brought up before, actually present with an element of a vestibular end organ dysfunction. That's usually the result of just forming within utero. There are a variety of common causes, and this is where I kind of go into the amount of children that come in and say they're dizzy. Sometimes it's basic things such as, hypotension, they skipped a meal, they have a viral illness. Sometimes it's just the side effects of meds, but sometimes it's also just attention seeking, unfortunately, but I do have to mention that. But there are some risk factors. So a lot of these are maybe ones that we all see as therapists. So those kids that are actually developmentally delayed. So if they are stumbling, they're not able to crawl, or they're kind of teeter-tottering, it may not just be because they're developmentally delayed, or that there is something in terms of their anatomy that's actually off as well. So very simple. What is balance? So it has 4 main components. It helps us identify where we are in our space. It helps us see clearly while we're moving. It determines what direction we're going and then how fast we are actually going. And it helps us adjust automatically to maintain our posture and stability. So I'm going to do a very brief anatomy review. And I say brief because the vestibular system is very complex, and I will touch on it just a little bit further. So as Brittany mentioned, our inner ear does consist of our balance system, which actually has 3 semicircular canals on each side, making a total of 6. Within those semicircular canals, each 3, they actually have their own little name. So we have an anterior canal, a posterior canal, and a horizontal canal. Now, within these canals, we actually have a certain type of fluid called endolymph that kind of flows in between. And there's also hair cells that respond to how we move as well. We also have the otoliths, which include the utricle and saccule, 2 on each side, so 4 total. Now, those semicircular canals, how I mentioned with the fluid within them, they're responsible for our angular motion, so such as like a yaw motion, a pitch motion, and a roll motion of our head. And then our otoliths, those linear motions, so a utricle is more of our driving or running, walking, where our saccule is more of kind of our up and down motion, so riding an elevator is the best example for that one. So as I said, it is a complex system in that within our balance, people just think, oh, it's just kind of standing on 2 feet, but there's a little bit more into it. It includes our visual system, the balance system itself, our proprioceptive or somatosensory, and as well as our brain. So within each big hub, there lies even more. So in our visual system, we have, of course, our eye muscles on each side. In our vestib system, we do have what's called a central portion and a peripheral portion. So the peripheral portion includes our otoliths, our semicircular canals, and our vestibular nerve, whereas the central portion is more vestibular nuclei. Then we have our proprioception and somatosensory. This is more of our spinal cord, our muscles, and our joints. And then lastly, our brain, which is our cerebellum and our cerebral cortex. So you may commonly see this just in your practice with people or patients speaking to you. So dizziness and vertigo, they are often used interchangeably. However, they actually describe 2 different types of sensations, and I do just want to kind of highlight those. So dizziness alone is a very broad term. It describes a feeling almost like you're feeling off balance. When they're dizzy, they can kind of have a stagger motion. They may say, oh, I look like a drunk person walking, or they almost just feel like they're always going to fall. Most of these patients will also add in that they feel very lightheaded. Vertigo, on the other stance, it's a specific type of sensation. These are where they kind of have that feeling as if they're actually spinning or the room is spinning around themselves. This is really, for someone who has this, they typically will also have nausea or vomiting along with this. And usually when it's vertigo related, it's typically a pathology that's causing this. So it's really not so much a diagnosis, but more of a symptom. Either way, both dizziness and vertigo can affect our balance and our movement. So some common causes, dizziness alone. So again, usually occurs because of environmental condition or underlying health condition. So I like to touch on some. So simply dehydration, so similar to what I spoke about with pediatrics, low blood sugar, low blood pressure, anxiety, head injuries, ear infections, and of course, medication side effects. Then our vertigo. So like I said, this is commonly done through a pathology. There's something underlying. So BPPV, Meniere's disease, vestibular neuritis, labyrinthitis, head injuries as well, medication side effects. So you can see there's some that actually overlap. So this is where kind of we come into play and you guys come into play to try and fine tune and see what's going on with them. But while I have you on this slide, just kind of bringing in from Brittany's perspective of hearing loss. So what we see in our patients, and this can kind of help us realize if this patient really has a Meniere's disease or neuritis or labyrinthitis. So a patient that has Meniere's disease, you'll usually see a low frequency fluctuating hearing loss. They'll also complain of like a low roaring tinnitus, or what we define as like a ringing, humming, buzzing in the ears. And then they will also complain of oral fullness. They'll just say it's full. And usually it's kind of a trifecta. They'll all occur at the same time and they can come in motion. So they'll be fine one day and then boom, it'll hit them. Whereas our vestibular neuritis, this is more of kind of like a viral infection. That vestibular nerve just kind of inflames. And like with anything, if it's inflamed, we kind of feel, not the greatest. And then they can sometimes feel that dizziness. But then we also have labyrinthitis. The difference between labyrinthitis and neuritis is labyrinthitis, it also comes along with a hearing loss. So that's kind of that red flag between a neuritis and a labyrinthitis. Neuritis, you won't develop a hearing loss. Labyrinthitis, you will. So that leads us to where do we come into play? So we offer a variety of tests as audiologists. So we have a VNG, an ECOG, a CVamp, Ovamp, VHIT, and Rotary Chair. I am actually going to touch on 4 of them. That we do actually here at St. Luke's. The other 2 I am going to also bring into play because I just want you guys to be aware and kind of see what we can also offer patients. So first up is the VNG, or the video anistomography. So this test is used to determine if a vestibular disease may be causing dizziness, room spinning sensation, or just simply a balance problem. So this is also looking at what we call that central and peripheral system within our balance. It does use infrared camera goggles. So just as you can see, our lovely little lady there, she wears these dark goggles. I will tell you, if your patient you're referring to us, if they are claustrophobic, they will not like this test. The majority of the tests, they are covered in just how she is, and it is done completely in the dark. So they're not the best. It does consist of 3 parts of this test, though. We are looking at ocular testing, so that's going to be our central finding. So a patient will just kind of follow a dot around the place, and we're recording their eye movements to see if they can stay on target. They also have positional testing. So within our positional testing, we have 2 types of positional testing. So we have static positional testing. These are typically non-localizing, and these are simply kind of just lay on your back, turn your head right, turn your head left, lay on your body right, lay on your body left. Versus our dynamic, this is what when we do the Dix-Hall Pike, and we want to rule out any type of BPPV. Lastly, we do caloric testing. This is the one your patients will probably be very angry about. This also looks at peripheral findings, and this is when we do put some cool air and some warm air into each ear 2 times. It's not fun. They will sometimes, I always say sometimes because everyone's different, experience that true vertigo sensation where they'll feel like they're almost like a hot dog at a gas station rolling on the heater. It's very brief. It lasts for about a minute. It does go away, but sometimes that's enough to scare a patient. And I will say this is probably the stand-in of this test, is that sometimes we can't complete it because patients just simply can't complete that part of the test. The big thing for calorics, it does tell us if there's a unilateral weakness or a bilateral weakness, or if both ears are working great together. Then we have ECOG, so electrocochleography. So we mainly use this for monitoring of Meniere's disease or endolymphatic high drops. So many physicians will actually send them to us just to kind of either rule it out or just see if we can get an objective. Now, I will tell you, if a patient is not in an active Meniere's attack the day they see me or they're not symptomatic, I'm probably going to get a normal reading. So that's the kind of downfall about this test. However, if they're not feeling the best, this is the perfect time. But of course, in the real world, it's almost nearly impossible that that's going to happen. But it is something to kind of put in the back of your mind that if it does come back clear and they're showing the red flag that they have it, don't be too discouraged. It's probably because they weren't in an active attack. It can look at the enhancement of ABR wave 1, which is another kind of form of testing we do. As Brittany mentioned, intraoperative monitoring. And of course, another part of the audiology side of diagnostic testing is auditory neuropathy. We can also look at it through these brain waves as well. Two of these tests. So it's called an evoked myogenic potential. So myogenic response stems from muscles or the neck of eyes in response to a high level stimulation. So the CVAMP I'm going to focus on first, which is that lovely lady you see right in front of you here. The CVAMP is looking at, C stands for cervical. It's looking at our saccule and or inferior portion of the vestibular nerve. So again, to remind you, that saccule, that's responsible for up and downward motion. So elevator riding. These individuals, they're not the best if they have neck issues, I will tell you, because as you can see, we do have them turned to an opposite side of a stimulus. And the point is we want this sternocleidomastoid muscle to pop out. The better that is, the better the response I'm going to get. This test alone can also rule out what we call semicircular canal dehiscence. It also can rule out some migraines. There's a kind of a whole plethora that it can also help, but it's mainly used for semicircular canal dehiscence and as well as any dysfunction of vertical motions. Which leads me to the Ovamp. So this is kind of more, I think, relatable to our populations, especially after concussions, just because some will complain they get dizzy when they run or walk or driving. So Ovamp stands for ocular. So this is looking at the utricle. So again, horizontal motions, driving, running, walking. This one alone also looks at semicircular canal dehiscence, but again, is more so looking at that utricle dysfunction. Going to switch gears now. So these last two are ones that unfortunately we do not offer, but again, I do want you to know that these are out there. So this one is called the VHIT or the Video Head Impulse Test. For my PTs, it's not the HIT, it's just a little bit of a remix for you. So it does, patients have 3 different types of eye movements with the VHIT. Normal, so they're remaining fixated on a target that's in front of them. They have overt saccades, which this is when a patient can make a corrective eye movement to the target that's in front of them after their head movement. So this is something that's visible to you. So this is more kind of like your HIT motion. Then we have covert saccades. This is when that patient makes a corrective eye movement during that head movement. This mainly is not observable to you guys. So this is something that we all miss. So as it states, it does detect the covert saccades. That's kind of the big takeaway from this guy. The video head impulse can validate that the head impulse is actually performed properly. There is a little computer that's of course connected to it, telling you if you're good or bad. The sensitivity and specificity are 95% with reduction in false negatives, which is huge. To give you a perspective for visual observation, the specificity is 34 to 39%. So overall, this test is a better comfort for them, and it's actually pediatric friendly because those little goggles are literally like swim goggles, so they fit pretty good on them. So because we're on that, I did want to demonstrate to you guys, especially for those who are not PTs attending today, what we're looking at when I mentioned covert saccades and overt saccades. So in overt saccade, I have a little video here for you. Turn that off. Okay, so I'm going to play this. So as you can see, that little eye movement that happens after the head turn, you can visibly see that. So I'll play it again. Maybe. Oh yeah, it just goes both sides. There we go. So that little shift in the eye. So that's something you as a provider are going to see during your bedside testing. Now, if I go to this covert saccade, I just want you to look real closely, see if you can catch it. I'm going to assume you saw nothing. This is hard because I can't tell. Stephen, did you see anything?
I did not see anything.
Okay, he confirms he did not see anything. So I'm going to slow that down over here just so you can see that that eye movement that was actually missed doing it visually. It is very slow, but it allows you to see the little eye jerk that is about to shift right there. Now that's something that the VHIT actually catches. So if we're looking for any type of abnormal saccadic movements of our patients, VHIT might be something to kind of consider for you. So this kind of leads me into this lovely graph. This is one of my favorite graphs. So more so for my PTs who you're sending to me and you're saying they definitely have a unilateral weakness, this doesn't make sense. Well, this is where I want to show you. So we have natural head movements right in the middle here. When we do a caloric irrigation, it is a very, very low VOR gain over here. So this is more of just sitting, just laying. So we're not moving. It's not uncommon to get a completely normal VNG on someone who is screaming a unilateral weakness. Now, if I go to the head impulse test, that's more of our natural head movements. So they're walking, if they're complaining that they're running or they're driving, things like that, that might be because this area right here is more of their natural head movement, but over here, it's not. So the VHIT, which leads me here. So on a caloric, I may get a completely normal caloric. But now if I do a VHIT on them, if we kind of highlight here, I have my left anterior, I have my left posterior, and I have my left horizontal. All these are in the red, which tells me that is actually a unilateral weakness on that left side because we're seeing some abnormalities and saccades going on. So my caloric may have been normal, but if I do a VHIT on them, that may show us that kind of, oh, there's the unilateral weakness. So I'll get to the point of what I mean by all of this coming up. I do want to touch on this guy, the Rotary Chair. I'll be honest, he's not my favorite. He's usually used to verify bilateral weakness just from a caloric testing. It can be formed with patients who even have a middle ear disorder. So if they have an active ear infection, you can still strap them in and go. It can look at the utricular function as an off-axis testing. However, I'm going to tell you it is very large. It is very expensive. It's not pleasant. Those are ski boots that they are locked into. It is like they're on a roller coaster ride from the worst place that they could be in. And in all honesty, it's very insensitive to a lot of peripheral vestibular findings. What do I mean by all of this? So I'm trying to get across it. It is a full test battery. So maybe one test alone may not be enough for your patient, but maybe 3 or 4 of them might be. So I just wanted you guys to be aware that is what we offer and what is out there for your patients. So maybe even if one comes back normal and you're thinking something else, can kind of remember back and go, well, let's try this test. And that may be your answer that you were looking for. So my takeaway is that we're all a piece to this patient's puzzle. So together we can actually put these pieces back and give them their life back. Whether you're an MD, PCP, a PT, or even another audiologist, we're here to help that same patient. So it's kind of one of those things, you know, refer, ask us. We're a team. There's no shame. There's no foul. If you're not sure, should I be doing this with the patient? Call us. More than likely, we'll be happy to ask or you some questions too of what can we do for our patients that you also see. So in the end, just refer and ask away.
Thank you. So what questions do you guys have? You can either ask by typing into the chat or turning on your microphone. All right, I guess one question that I have is if patients, if you're concerned about a unilateral weakness that's causing some of their balance dysfunction, would the VHIT be your first go-to test?
It's honestly easy and fast, and it's really more so used in PT than it is audiology. It was actually made in mind for PT because what it's going to do is it's while you're doing that bedside HIT testing, strap the goggles on, and you're going to get an accurate reading of just 1 your hits. But you can also look at the other two canals as well. So just not the horizontal, you can actually do what they call RALP and LARP. So you right then and there can see, oh, the left side is much weaker than the right, and then you can kind of go right into your rehab that you do with them versus kind of making them wait, sending them to us till they get to see us, and then either finding that unilateral weakness with calorics, awesome, or if we come back and we say calorics is normal, then it's kind of, oh no, now what? Yeah. So I don't know. I guess I'd say, yeah. I'm a fan of it. I love it. I used to work with it up at Hershey, but it is one of those that it's very quick. It's very quick, very easy. It's really only 20 quick bobs of the head and you're done. So you get a lot of information just with really 3 minutes at most. Yeah.
Is that something that you would recommend? So if we don't have the equipment to do so, would that be something we just put in an order for?
Yeah, you can. Yeah. We can't give that to you, but there are clinics that do have that equipment, so it is out there. Okay. It is, but yeah.
Right. One question that was asked is insurance reimbursement available for hearing aids for the testing services?
Oh. So for comprehensive hearing testing, yes, most insurances cover the hearing test. Some insurances will stipulate, like Medicare, they'll only cover one comprehensive hearing test every calendar year. If you're referring to hearing aids, there's actually been a lot of changes very recently, and we're all still kind of weeding through it. For the most part, there's not a ton of reimbursement rate for hearing aids, and some insurance companies are actually partnering with third-party dispensers, not audiologists. These dispensers tend to be hearing aid instrument specialists, which is one of those situations where you can kind of write a check and fill out some paperwork and get your degree and dispense hearing aids. So it's kind of unfortunate right now, and we're kind of waiting to see what's happening. But insurance does cover hearing tests. It doesn't typically cover hearing aids.
Unless you're a kid, usually that's medical assistance. Yeah, up to 21 if you're on medical assistance.
What other questions do you guys have? All right. Well, thank you very much. And as I mentioned earlier, please make sure you complete everything in my e-learning to get your CE, your CME, and I will see you guys next month. Thank you very much.
All right. Thanks for coming.